I'm going to talk on traumatic cataracts in children. No financial interest is there. Now, etiology of the traumatic cataract would vary from all the five which I mentioned. First two are very common, and then less common is ionizing radiation, shock, infrared energy, sometimes rare. Challenges compared to, say, cataract size, any routine cataract surgery in the child is also a challenge. But trauma is an additional challenge because of often associated injuries to the other ocular structures. Visualization can be poor because of the corneal obesity or the wound itself. Poor cooperation, especially in acute situations. There is post-operative, pre-operative, you have to deal with additional risk of inflammation, increased risk of infections. So your post-operative becomes fraught with a lot of complications. If you do plan your environmentally remains unreliable for many months. And not to forget, these children will not really have endless time to wait and watch until the skin stabilizes because there is a risk of family always lurking around. So when you do see a child with trauma, your workup should include a detailed history about the regarding the injury. However, just an idea here, don't believe everything what the child tells you or parents tell you. So you have to keep a little bit of your suspicion intact. You may have to require most of these children invariably require surgery. So you have to take care of a little past ocular medical history, especially things which may affect anesthesia, like sickle cell disease or a bleeding disorder. Record vision whenever it is possible. A lot of times, surprisingly, we always are very happy to try to vision and cooperate or not responding, but many of these children may respond. And it always gives you an idea about the status of the other eye, which is very important when you plan surgery. Careful anterior examination, I cannot overstate this. Horizontal evaluation also surprisingly, most of us don't even attempt. It is possible in a certain percentage of patients, it's possible. So if possible, you must make an additional test as required. Now let's look at the scenarios where you may have cataract. Cataract may be associated with open globe injuries, where there is loss of integrity of the ocular pore. There is an increased risk of infections in this case because it's a perforating injury or something has gone in. As well as inflammation in the post-operative period. You may have, in addition, a rupture anterior as well as posterior capsule, or either or all. There may be lens-related issues like fundal dialysis or dislocation. So this is a particular situation where you may see them in the emergency. Here, luckily, imprinting object that pencil case is still lodged there, but you can see there is a cataract and there is a perforating wound. So how do you deal with these situations where there is a primary wound repair also involved along with cataract? Always, wound goes here first. Whatever the primary perforating trauma must be closed first. If you feel that you can handle it with the cataract, if the lens is ruptured, you have to remove the cataract and do it through a separate scalp incision rather than doing it through the wound or anywhere else. Do not implant IOL in the primary wound repair setting. However, every attempt should be made to preserve capsular support for a secondary IOL later. In the event of a ruptured posterior capsule, don't do a half-vitrectomy. Clear the vitreous whatever has collapsed and do a complete vitrectomy wherever it is indicated. So these are the situations. You may not have an acute wound, it's a wound which is seen, as you can see, anterior chamber is formed, but you have a lens rupture. So you may require to do sometimes cataract surgery where the wound is either seen or somebody has repaired it or you have repaired it earlier. In those situations, your key of timing of surgery is what is the status of the anterior lens capsule. In the picture where I showed before, you really don't have time to do that ruptured anterior capsule. The fluffy cortex which is there in the anterior chamber is going to incite reaction, is going to cause a rising intraocular pressure. So there you may have to do it even if the situation is less than ideal. So early surgery in case if you see a ruptured capsule. However, if you don't see a ruptured capsule, you can wait on them for 2 to 7. Ultrasound in situation where there is no frontal examination possible is absolutely mandatory. UVM, if you feel the child is having stable and their chamber is the wound stable, you can ask for that if you suspect something. DVR may be possible in a small cell-free injuries, but in large wounds sometimes you may not get it in the initial phase. But you may still have to go ahead and require second year or later. You may require topography if the body is very irregular, you are not able to get. Sometimes it's a good idea to get skin data which will give you an idea about the cornea. So as you can see here, there is a rupture in the capsule. And sometimes stay in it despite being a ruptured capsule and not get the excess. It's always a good idea to have a regular margin on the capsule so that you have a reliable support. Even if you do not have what we call an alignment axis. And then you can aspirate the cortex. And as you can see, once the cortex is aspirated, you can see a small that's stayed in the center. So here in this situation, once you have aspirated all the cortex, then you can just I usually make the wound before the tractable because sometimes I become soft to make the wound at least. So in this situation, we have to put a surface fixation 3D lens, which is taken and then so as I mentioned earlier, it's not preferable to use if you don't have a DVR. Don't use standard K or DVR of the contralateral light is just an idea. Secondly, I was safety plan after 6 to 8 weeks. In this case, I was able to get the DVR. The video that I showed, I was able to get a small wound. I was able to get a DVR and so I put a lens. But in case if you are going, if you have a large wound where DVR is not possible, do not use a standard K or a DVR of the contralateral light. You can do the same thing after 6 weeks and put a lens safely. Once you get really stabilized. It's important, it's very important to see the fundus on table from the point of further management as well as the prognosis in these situations where we did not have a fundus earlier. And if whether you have placed the lens, whether you have not placed the lens, it's important to always keep amblyopia and visual rehabilitation in the mind, whether with the contact lens or with the glasses as after the surgery. And this is just to show why I thought the fundus examination is essential. These two patients had excellent cataract surgery, but you can see why they are not going to get good vision post-operatively despite having an excellent essentially placed either. One of them has a macular hole behind, one of them has a rupture which is added to the macula. And these are both my patients, so I know. Some surgical costs, topical steroids and cycloplegics definitely before surgery in these cases helps if there is a rupture at the capsule with cortex inside in that region. A close watch of infection, especially if the wound is fresh in the immediate post-op period, is very, very essential. If you are doing it in a cataract surgery in a fresh suture wound, please make sure you check the integrity of the original wound before you close the suture. Because a lot of times with your surgery, the additional fluid flow, there might have been some loose suture or something which may have given way, and that will leak the next day, and you will get yourself into getting into a second procedure, which is very, very distressing for the parents. So after you have closed everything, just go and check the integrity of the original wound just before you close the patient. And plan to check out in this situation, even if the child is older, you feel you can do AI, because there is excellent paper that today which was sent, even in traumatic cataracts, even with posterior capsulotomy, the chances of PCO is very, very high. So if you've not done it, you will end up requiring many capsulotomies. So it's probably, even if you feel that child is cooperative for capsulotomy, it's probably better to do it on the day. Now we're coming to the cataracts, closed loop trauma or a blunt trauma. Again, here cataracts can be associated with whole spectrum of injury. The cataracts, as we all know, is important. And here also, despite being a closed trauma, you can still have an anterior posterior capsule rupture along with along with the cataract. And your cataracts may have to be modified by the presence of other issues like hypema or glaucoma, which is pre-existing. So these are all the situations how the glaucoma can present. You can have corneal lacerations, you may have hypema, you may have a subluxated cataract, you may have just a cataract with a fibrous margin, you may have another precision along with it. All these are possible with completely intact ocular pores. So here, again, when you do surgery, other issues like glaucoma and hypema need to be taken care before surgery. Even if the eye looks quite, be prepared for an inflammation spike just after the surgery. So you have to give adequate topical steroids. If there is a postcapsular rupture, which you can see on the table, which you have seen on this example, or you suspect it, then when you do the surgery, keep all your settings low. Aim for a smaller axis to ensure an adequate support from an eye and and let me tell you, this traumatic postcapsular reason is slightly different than what the last videos were there and what Dr. Sandeep showed. These are because the vitreous is a little fluid thanks to the injury. In this case, you are likely to have a dislocation of the cataractous material behind. I just show a video here. Unfortunately, I'm not going to insert it in that case, I did have a postcapsular event, and I had to ask my retina colleagues to see here. I did suspect a postcapsular axis. I have gone with a retractor instead of a regular bimanual cannula, but my fluid turbulence is. I should have stopped here, but I stopped a second late, and as you can see, it is the vitreous has collapsed, and unfortunately, a lot of cortex went down, and I did have to seek the help of a vitreoretinal colleague to hear. This was a problem which I faced because I went with my usual settings. I should have reduced my blood water height and should have stopped as soon as I saw a little bit more turbulence in my anterior chamber. But in these situations, also it is possible to place an IR even if you have a large net. As you can see, the second patient is the one where the video on this, the picture on this side is the patient whose video I showed. You can see a very large postcapsular rent through which the collapse of the cortex, which is located in the vitreous cavity. But I was able to place the lens because I had an access here and the child is doing that. Now, what do you do with cataract, which sometimes in our situation comes many months later when there is a old trauma and it has been neglected or not sought treatment or things like we always see. So this often the surgical technique is to modify it a little bit. It is often associated with partially absorbed or membranous cataracts, and here anti-capsule may be very fibrotic and adherent sometimes to the PC. And you may have to consider cutting that membrane which is in the center, even as I said, even if the child is older or they may be teenagers, but they come to you. Cortex is again calcific, and sometimes it is easier to use your phaco to aspirate this calcified cap cortex than your regular aspiration camera which you use. Again, just to stress that point, do not use a single recycle if you don't have a bag. As you can see, it's a very fibrotic cataract, and it should have been very difficult to visualize without staining. And sometimes you have to do it really gently, that's able to get the excess of this patient. And as you can see, it's almost like a black thing. The cortex is so, and sometimes very difficult to aspirate into aspiration camera. And phacotips, because of the simple physical fact of having a large bore, it is easy and fast. So you can use in such situations. Now, secondary, again, as I said, there are lots of situations where you may not be able to place IOL in the first setting, in the setting of the trauma. So in secondary IOLs, you must have some guidelines about. There are no clear guidelines about when you should do secondary IOL. But probably the key factor is whether you have a stable and reliable biometry before you do a secondary IOL. Again, do not implant single iris, implant IOL in surface. Clear corneal decisions are always preferable when you are doing a secondary IOL because you preserve the conjunctiva and have long mobility factor for it. You expect a lot of extensive synegia, and it's always a good idea to use scissors to cut the synegia rather than a spatula because which can be very, very traumatic. Sometimes pupilloplasty helps if you have, because after you have removed synegia, you will find the iris vector is almost completely disturbed, and you will all the time as you remove the lens tends to come forward and it does not have to move. So sometimes it's good idea just to put a small suture there. So I have two videos here. Here, as I said, probably you use synegia. Sometimes it is not possible to use synegia because it is really tough that time. So it's sometimes easier to use a scissor like this to cut the synegia, keeping the plane between your iris and the capsule. Yeah, you may expense a very expensive bleeding sensitive, and it is more of a test of patience rather than, but it is probably spatulized much more traumatic. So it's probably difficult to use the spatula. I have a last video also here. Before you plan any surgery, my last two slides, most of the parents, when you do a children with traumatic cataracts, one, realistic picture, no comments on prognosis till the surgery is often the best approach. Don't say positively, don't say negatively, say I don't know because you don't have all the information available at the time when you are seeing the patient. No time to explain of possibility of not implanting IOL because a lot of times there is a huge pressure on doctor to put the IOL, but it's always best that there is tell the parents, even if you feel that you will be in a good place, because sometimes trauma can be unpredictable, not given. And so it's always better to prepare the parents for a small possibility of not implanting IOL in the primary setting. You must stress the need for lifelong follow-up, definitely. And this is something which you can never die. You should probably repeat it in every post-operative visit, the same thing. Need for further procedures like requiring for glaucoma or membranes, you must prepare them right at the time when you plan your primary surgery. You must talk to them about, even if you are going to put an IOL child, you still need glasses, he will need mainly patching. All this must be talked before surgery. Prognosis, stay away from telling what. And the last but not the least, visual rehabilitation. It's not enough. If you leave the child looking like this, white eye, IOL, center, no, job's not done. You may need appropriate correction after that. Sometimes with extensive trauma, with a scarring in the cornea, you may need a contact lens despite having an IOL in. So you must plan for that in case if you are not able to get a good correction after that. Hypotherapy, no need to stress this to this audience here. And you need a lifelong monitoring for visual access, intraocular pressure, and retinal status in a day. Thank you for your time.